welcome back to my channel in the new video. And this particular video is a very short video and a very kind of a basics of Ecmo. I'm sure I'll come out with the advanced techniques and few intricacies related to Ecmo in my future series. But as of now, in this video, I will be talking on a very basic of Ecmo for the learners or for someone who have started knowing or doing Ecmos. So as we know, ECMO stands for extracorporeal membrane oxygenation, and it is mainly for refractory cardiac or respiratory failure. Now, for someone, uh, for want of easy understanding, that is my phrase, I think I'll put it as lung dialysis. So, I'm sorry. So, basically, it is nothing but an artificial lung, as we have artificial kidney, and you take the control of the body on that artificial lung for better oxygenation. And of course, in the situations where you have a cardiogenic shocks or poisonings or ECPR kind of situation, where we actually get indulged into VECMO, and we'll come to that, to increase the cardiac output. So this is prima facie and the premise of the talk as to what the ECMO do in the body. So as we could see that you have a particular patient where a wider bore venous catheter is put in the femoral vein from where the blood comes out, and of course it will go to the pump where the pump will pump the blood further, and of course it will go to the oxygenator or the flow meter or the lung, which will oxygenate the blood. And here you will be attached with a flow meter to deliver the oxygen, and of course the sweep setting where they are primarily dealing with washing out of CO2 if the patient also has respiratory acidosis along with hypoxia, and the return blood, which is red in color, which will be returned through IJV cannula inside the body. So this is essentially a very simple schematic diagram which tells us about how the ECMO functions. So this is the return cannula, and this is the return cannula, and this is the drainage cannula. So the types of ECMOs are the venous ECMO, which is primarily for the lung diseases like ARDS or ILDs, and we'll come to that. Whereas VA ECMO or a veno arterial ECMOs are predominantly for the patients who have cardiac ailment or cardiorespiratory ailment. So this is a very classical CT scan of a progressive or worsening ARDS, where we would consider an VV ECMO for this patient. So the ELSO guidelines, which are the standard kind of guidelines which are followed across the board, and these are the indications of VV ECMO in the form of ARDS, refractory hypoxemic respiratory failure, type 2 respiratory failures, or we can do an ECOR, that is a carbon dioxide removal. And of course, we should remember that they are bridge to recovery or bridge to transplant. So if you are going ahead and doing a lung transplant, then it will be prudent for that patient to undergo VV ECMO. As far as VA ECMO is concerned, of course, cardiogenic shocks, ECPR, post cardiac surgery if the patient does not improve, few poisonings, especially the paraquat poisonings, or in few even OP poisonings if they are not improving, and of course it is a bridge to transplant. So in this particular VA ECMO, it will be bridge to the heart transplant. So this is in the nutshell as to what are the classical indications of ECMO, either VV or VA. So the contraindications are, of course, the absolute contraindication includes uncontrolled bleeding, irreversible brain injury. When the patient is not for resuscitation and advanced age, you need to refrain these patients from taking on ECMO. whereas relative contraindications being high intracranial pressure, major stroke, and the futility of the efforts if they have been discussed. So as I said, these are the components of the circuit. So if this is a drainage cannula which actually sits in the area where there is the distal tip, which is just proximal to the hepatic vein in IVC, just before the right atrium, and it is guided by a transesophageal echocardiography, which is done intra procedure. So this drainage line which comes into the pump, so the pump which will push the blood, and one of the connection is to the console, that is the machine, and another connection is to the oxygenator, where from here you have a blender oxygen source. So that is a blender or the oxygen source, and here you can actually have a option of a heater or a cooling of the blood which comes into this oxygenator, and after it gets oxygen source, as you could see, from this oxygenator or the lung, the artificial lung, the return blood which goes through the return cannula inside the right IJV. So this is how the whole circuit looks like. uh, how do you initiate and monitor this patient? So you have a ramp flow of about 60 to 80 mLs per kg per minute. Heparin is a standard anticoagulation to maintain the ACTs between 180 to 200. Monitor the transmembrane pressure of less than 350, the SVO2 of about 70% and more, and we do a neurological examinations every 4 hourly, daily echos for these patients, daily lactates, and of course you need to have a vigilance on the troubleshooting, mainly in terms of clots or air or obstruction of either of the cannulas. And these are few of the complications of ECMO, that we may have intracranial hemorrhages related to the coagulopathy, pulmonary hemorrhages, cannulation failure, which can be encountered right at the time when we initiate the cannulation. Sepsis, if they prolong, or if there is prolonged ECMO therapy which is going beyond 5 or 7 days. Leg ischemia, so there are a few complications related to the vascular injury, the GI hemorrhages, and the cardiac tamponade. So I think the pearls of wisdom is the early the better. So you have the criterias of also into this also. So you have initial 3 to 4 hours of hypoxia and about 6 hours of hypercapnia. So you need to have this thing in your mind. But early is always the better for a right patient, right time, and the right place. If the center is well equipped for ECMO, of course you need to go ahead. But if you have a slightest of confusion and doubts, it is always better to shift or transfer this patient to an ECMO unit. Multidisciplinary team dynamics, you have cardiac surgeons, intensivists, anesthesiologists, physiotherapists, dietitians, nursing staff, which is the most important part and parcel of this team, the respiratory technicians, the ECMO technicians, the RRT if they are required, and the most important and not the least is of course the perfusionist. Now complications are the rule, they are not exception, and this is what the statement which I think I need to emphasize. And of course we need to communicate with the family as to what are we dealing with on day to day basis, sometimes multiple times in a day, and we need to actually counsel them, we need to brief them on fairly frequent basis. So as I said, this is the team which consists of all these team members, and that is the probably kind of the success which lies on all these team dynamics, which is secret of the success. The ECMO saves lives when used early, selectively, and thoughtfully, and it causes harm when used late, indiscriminately, or without a plan. So this is probably an important message which I want to give. So that's all for now. I think it was quite a brief talk, but it was just to start or initiate or to sensitize the minds of the people who have just started using ECMO. And I'll come with the more advanced and more parts of ECMO in the future or the further series. So that's all for now. Thank you.